Good afternoon, everyone, and welcome. So what we're going to be listening to today is orofacial pain from an acute management perspective, so the primary care impression. I'll talk a little bit about what happens in oral medicine. Mr. Kumar is here and he's going to give us our surgical perspective, and we're welcoming Christina from Peter Mac, who's a clinical psychologist, who's going to give us a bit of a psychological perspective. So Rad is a general dentist in primary care here at DHSV and has been working at RDHN for over 3 years. She originally graduated from the University of Leeds, England in 2013 and has worked with the NHS in the UK for 2 years before moving to Australia. Stephanie is a general dentist in primary care here at DHSV. She graduated from the University of Sheffield, England in 2013 and has been practicing in Australia now for 2.5 years. There'll be myself, and we're going to hear from Ricky. Ricky is the Director of Surgery here at RDHM and also holds public appointments at the Royal Melbourne Hospital, the Royal Children's Hospital and at Monash Health. He's also a supervisor of surgical training at the Dental Hospital and at Dandenong Hospital. Ricky enjoys providing general max-fax service, having particular interests in dental alveolar surgery, implantology, oral pathology, facial trauma. His subspecialty interest areas are paediatric max-fax surgery, corrective jaw surgery, and TMJ surgery. And Christina, thank you, Christina, who was kind enough to help us out at short notice, and I'm extremely grateful. Christina is a clinical psychologist at Peter MacCallum Cancer Centre in Melbourne. As part of this role, Christina has been involved in a range of clinical projects, including overseeing the implementation of a psychological screening program for men being treated with prostate cancer, development of a pre-rehabilitation service, and integrating psychosocial services for patients within the acute and persistent pain service. Christina also has clinical and research experience in the areas of adult mental health and chronic disease. So let's hear from Steph and Ray, please. Thank you.
Thank you very much. So yes, my name is Stephanie and this is Rad, and we're both general dentists in primary care. And we're going to talk to you about how to recognise non-odontogenic pain. As you all know, pain is a subjective experience. So when a patient comes in, regardless of what us as clinicians can see when we look into their mouths, if a patient says they're in pain, then they are in pain.
So focusing a bit more on acute pain, the duration is usually 3 months or less, but 3 months does not have to be a cut-off point. It's associated with tissue damage, with the expectation that if managed adequately, healing will occur. There are two main types of pain, nociceptive pain and neuropathic pain. Toothache itself is nociceptive in nature, which means it occurs in response to a stimulus, whether that's chemical, thermal or mechanical. Particularly within teeth, there are A delta and C fibers which respond to the stimulus and send a signal to the brain indicating the presence of pain. It tends to be well localized, which means when patients come in complaining of toothache, they are usually able to report on it quite well.
So there are different types of acute orofacial pain. There's dentinal, so when there is exposed dentine that can cause sensitivity. Pulpal, so involving the nerve, for example, reversible or irreversible pulpitis. Gum disease doesn't tend to cause pain, but if there's a periodontal abscess, then that may. An example of mucosal pain could be an ulcer. Temporomandibular disorder is a musculoskeletal source of pain, and it's important to remember that that is the majority of non-dental pain. Sinusitis and salivary glands, they're a bit more complex. They involve other structures, so sometimes it's valuable to get a specialist opinion, such as ENT. And then there's post-operative pain. So these are some examples of what a patient might say when they present. And really, if a patient is saying these sort of comments, then it could be worth really thinking about, could this be a non-odontogenic source of pain?
So it's really important that when dealing with a patient emergency that you get an accurate pain history anyway. A few of you may be familiar with the acronym Socrates. It's just a way that it allows you to question the patient in more detail to get an accurate experience of the pain that they're experiencing. So you have S stands for sight, then you've got onset of the pain, the character of the pain, so is it dull, sharp, throbbing? Does the pain radiate anywhere? Any associated symptoms that the patient can come up with? The time course of the pain, so how long does it last, or does it come at any particular time of the day? Any exacerbating or relieving factors. Normally with tooth pain, you kind of get the sense that either hot or cold can sometimes make it better or worse, and the severity of the pain itself. Now, patients may not always see the value in asking them lots of questions, and clinicians may feel time pressured, but that shouldn't stop you in getting a detailed and accurate pain history. As well as the presenting complaints mentioned earlier, there may be specific warning signs that you come across, which may trigger that it could be non-odontogenic pain. So, for example, patients may mention that the pain they're experiencing actually started some time after an original injury or treatment that they may have had. They may use describing words that you wouldn't normally associate with toothache, such as tingling, burning, itching, pins and needles like pain. And they may also say that they've seen multiple different clinicians and have multiple different types of treatments, but not actually gained any resolution of the symptoms that they have.
So a thorough examination is very important. It's essential to listen to the patient and then look to expand the examination depending on their presenting signs and symptoms, rather than perhaps focusing on one particular tooth, really listening to the patient and understanding what their presenting complaint is and then expanding accordingly. So that will bring us to a diagnosis. So in this case, we're looking to exclude an odontogenic source, and it's still very important at this stage to acknowledge the pain. So it can be that many chronic pain patients feel that they're just being dismissed at this stage because nothing has been found. So they're the ones that can become very difficult to manage in the future, and they're just keeping on seeking treatment because they haven't had an explanation. So really the worst thing to do at this stage is to say, nothing is wrong and send them away. It's really important to provide an explanation.
So that brings us on to the management. So we've excluded a odontogenic source. The best thing we can do for these patients is to listen to them, listen to their side of the story, what they're experiencing, empathize with them, and even apologize that they're experiencing this. We explain to them that through our tests and investigations, we can't see any decay or infection or disease, but there are other areas that pain may be coming from, such as nerves or muscles. And the best course of action would then be to refer them on to a specialist to have these areas investigated themselves. So it's a lot of reassurance, and finally referring on to specialists. If we can't see anything as clinicians, we shouldn't be pressured into treating something that we can't see is there. So finally, remember that not every pain presentation will have an obvious source. Consider the sensory supply in the region. So it's important to note that pain does not cross the midline and it doesn't spread across multiple divisions of nerves. And as Steph mentioned earlier, the most common source of facial pain is temporomandibular disorder. And if you don't have a diagnosis, please refer on or just ask for more help. Thank you.
Thank you, Steph and Rad. That was excellent. And we know what it's like to have a patient in the chair who's distressed and in pain and expecting that immediate pain relief that most of the time you can give them once you give them the LA. And it's also really stressful when, as both for the patient and the clinician, when you don't have a clear-cut diagnosis either. So you're doing the right thing, you're acknowledging them, you're not sending them away, you're saying that they're going to give you some help, they're going to refer you to oral medicine, and hopefully we'll be able to get them on the right track. So we know odontogenic, acute, nociceptive, so physical, chemical, thermal injury, it hurts, it heals, the pain goes away. Once they come to oral medicine, what we're hoping is that, yes, you have ruled out an odontogenic cause of the pain. We have been known to get out a CO2 stick in oral med every now and then. And so chronic, 6 weeks, 6 months, 6 years, it doesn't really matter. There's no clear cut-off mark when one becomes the other. And neuropathic. So neuropathic is a term that a lot of lay people are becoming familiar with now because nerve pain is being advertised. You know, we have got treatments for nerve pain now, and this your type of pain. And so people are becoming more familiar that there are different types of pain. That doesn't mean that there can't be overlap. All right, so we see pain patients regularly because we're not necessarily curing them. So they come back for review and we ask the same questions over and over, and we examine them, because just because you've been labelled with a chronic pain condition, it doesn't mean that you can't develop new pathology. So these patients can get toothaches, they can get other diseases, and so we need to examine. And then there are patients that live with both, and arthritis is a perfect example of someone that is living with chronic pain, but also has, you know, acute nociception coming from those inflamed jaws. So we know that chronic pain is useless. It serves no useful purpose. And the thing that we have to note with chronic pain is that we have these associated symptoms, right? Now, some of those symptoms are there before the patient develops their chronic pain condition, and some of them come afterwards, but a lot of them are there for the whole of this patient's journey. And this is the basis of taking a biopsychosocial approach to the management of chronic pain. And Christina, our psychologist, will be talking a little bit more about that later on. Chronic pain is predominantly neuropathic in nature. And now we have this new word, nociplastic. So neuropathic, as defined by the International Association for the Study of Pain, says you must be able to identify a lesion or disease of the nervous system. You must be able to see it, you must be able to measure it. And these are patients who've got post-herpetic neuralgia, or they've had a stroke, or they've got multiple sclerosis, or something like I said, that is measurable. But what this definition does is it leaves out a whole lot of patients that have pain for which we can't see what's causing the pain. These are our fibromyalgia patients, now also known as chronic widespread pain. These are also patients with, you know, non-specific low back pain, irritable bowel syndrome, restless leg syndrome. So these type of conditions. And so what nociplastic is doing is saying, well, look, we know that there's something wrong with your nervous system, and what's been relayed back to the brain is not correct. Plastic referring to neuroplasticity. So we know that the brain is capable of learning and growing and developing and changing, and people who've had brain injuries and who've had strokes can learn to walk again and talk again. That's the positive effects. The negative effects can be evident also, and so someone that develops a chronic pain condition can go on to have worsening pain as time goes on, and their quality of life parameters really, really deteriorate. So now when we start to look at classifying orofacial pain, we have to think of it on this background of nociplasticity. Dentoalveolar hopefully the dentist can look after that. Musculoskeletal, primarily, we look after temporomandibular disorder, and then we come to these neurovascular pains. This classification is a very, very brief summary. The International Association for the Study of Pain has a classification that has like 400 pain syndromes, and it covers head and neck really well. We are using, in oral medicine, we like the International Classification of Headache Disorders, and it makes sense to us, and it's a little bit simpler, but then it doesn't cover TMDs very well. So then we have the American Academy of Orofacial Pain, and they do TMDs really well. So there's no one perfect classification system. But why do we need to classify? We need to classify so that we're all using the same terminology, so that we've all got consistent diagnoses, basically so that we're all on the same page. Now that means that we can talk about these patients. It means researchers can look at homogeneous groups. It also means that we can then use evidence-based successful treatments and then hopefully go on to individualise those treatments and hopefully get a successful outcome for these patients. There's lots of acronyms. Have we got So the one, obviously TMD, we all know about. The ones we're using mainly now, PTTN, post-traumatic trigeminal neuropathy, burning mouth syndrome, persistent idiopathic facial pain, and trigeminal neuralgia and post-herpetic neuralgia. These two, this one, yeah, it's still not wrapped in, I didn't know. Okay. And this is what's replacing the old terminology. So we don't use phantom tooth pain. That sort of went out of fashion in the 80s. Atypical odontalgia and atypical facial pain. And we're now replacing those, and we're saying, well, look, we understand that these post-traumatic trigeminal neuropathies are really what the old atypical odontalgia was. So patients would have a procedure, the procedure would be completed, and they still had pain. And so this is because of irritation of nerves in the area. And persistent idiopathic facial pain is sort of replacing the old atypical facial pain. These figures are a pretty good representation of what we do see in oral medicine. The majority of it is temporomandibular disorder, followed by burning mouth syndrome. Then we have the PTTNs, trigeminal neuralgia. The others haven't been measured because there's just not enough of groups of people with unusual neuropathies to say how often does it actually happen, what the incidence is in the population at the moment. But these are the diagnoses. These are our most common diagnoses in oral medicine for our chronic facial pain patients. I mentioned this just a little bit earlier in terms of those comorbidities and what goes along with treating chronic pain patients. You can't just treat the biomechanics or the pathology. You have to look at the psychological and the social factors. I love that marital status is there because evidence has been, there is evidence to prove that married men are healthier. They haven't done it for women, and I suspect it might have a negative impact, I'm not sure. So risk factors, much like warning signs, is that you can have the same two patients, both female, both the same age, same diagnosis, same tooth that needs extracting, same uneventful extraction. But because of that patient's life circumstances, one patient will go on their merry way and be pain-free and happy, and the other one might develop a post-traumatic trigeminal neuropathy that makes her life and your life absolutely miserable. And so you need to glean as much information as you can from your original history to make sure, to see whether you can identify these patients. It would be lovely if we could phenotype them, and who knows, perhaps one day we may actually be able do genetic testing and know which patients are going to go on and develop these painful conditions. So management, much as what everyone does, education and reassurance, and we do an awful lot of talking in oral medicine, okay? We do have to have shared goals. Not only do we talk a lot, sometimes we're the first person that said to this patient, you're going to have to live with this, we can't cure this, and that can be really distressing for some. As I said, we talk a lot. Most patients, fantastic, they take it on board, and as we have the benefits of long consultations, we build rapport, we see them for months, we see them for years, and they do learn to live with it. Other patients think it's a complete load of BS, they're out the door, they're doctor shopping, they're cure seeking, and they're on a mission to get that cure. In terms of medications we do prescribe, I think of it as like a top 4. We prescribe antidepressants and anticonvulsants, not for depression, obviously, not for seizures, but because of how these medications work on those neural pathways. The antidepressant, first-line treatment, amitriptyline, been used for over 40 years, old-fashioned tricyclic antidepressant, much like we use Tegretol. You know, some people think dirty old drug, but really works very well still for trigeminal neuralgia. But mainly we're looking at amitriptyline. We're looking at duloxetine. Some of you might have heard of Cymbalta, and that's one of the newer generation antidepressants, which is an SNRI, which has become very useful in chronic pain. And the two main anticonvulsants that we're using for pain is gabapentin and Lyrica. Lyrica's had a bit of a bad rap in the press lately, but if it's used properly in the right circumstances, I think some of the issues were that people were using it as an analgesic and not as medication for neuropathic pain. And we know that for chronic pain, simple analgesics and stronger analgesics like opioids don't work in this type of pain. In terms of the referral, that is that we get there when we've decided, not that we've decided, but between us we have determined that this patient no longer needs any further investigations. They don't need any interventions. They need counselling. Some of them need a multidisciplinary approach, and as I said, Christine will touch on that. But for those that perhaps still need some investigating and intervening, we have our surgeon. That's a nice segue into Ricky.
So before you start, Ricky, I just wanted to check, has everyone logged on to Slido? And I didn't mention the code to enter in. I'm not sure if you saw it on the screen, but it was DHSV. So just if anyone didn't get that, I apologise. But yeah, the code's DHSV, and then that will take you straight into when questions are loaded. Now, just bring this up, Ricky.
Yeah. Thank you for having me here. I'd like to start off by saying thank God for oral medicine specialists. Without them, we'd be in trouble as surgeons. What we can't fix, we give it to them. And this here is not the face of the patient. It should be the face of the surgeon when you've operated and you're in trouble when the chronic pain is not gone away. So we all remember the cortical mentalist man, and benefit to us, he's got a big sensory cortex representation face, so we're all in business, right? What I want to talk about here is causes of pain from a surgical perspective. So odontogenic, so I'm going to go through some of the things we can operate on and some of the non-odontogenic things where we operate on, and towards the end, focus on when not to operate in TMJ disorders. Let me use this. Pretty simple, right? Needs surgery. These patients are in chronic pain, and this happens to us all the time. Not even just DHSV, it happens in private practices. Patients present with masks like this, and you think, oh my God, they've been in pain. All you can do is full dental clearances, and the pain resolves. Easy. Bread and butter for oral maxillofacial surgeons, 90% of our private practice is probably based on this, is impacted wisdom teeth, and it come out, pain resolves. Surgical management. Then you can get these things. Facial space infections. You can understand why someone like this has pain. Acute pain, infected wisdom tooth, scan showing airways only that much, needs a surgery. Again, easy acute pain requires surgery that resolves the issue. So these are all odontogenic causes. Then you can get slightly something like that. Someone presents with swelling in the maxilla. It's an impacted tooth. You can see someone's taken all this teeth out and not realize there's still impacted in there. I don't know how that happens. Cone beam scan showing a nice little dentition cyst around it. And then you open it up, you can see the canine say hello, and you take it out, and pain resolves. So these are all acute odontogenic causes where it can be resolved. I've just returned from Fiji yesterday, and this is another cause of odontogenic pain. This is an OPG someone presents with, a benign tumor ameloblastoma. You can see much of the jawbone is eaten away. The teeth are sort of falling. I know some people are having lunch. Apologize. We did take the jaw out there. Okay, so that was a very quick cap on odontogenic reasons for doing surgery. And I think no one argues that that's pretty straightforward. Now we're going to talk about non-odontogenic issues. Sinus. So how many times does someone present with pain in the maxilla, and you look at the teeth and you go, it's all looking pretty good. I've done the, what do you call this? CO2 testing or something. And you go, well, teeth are fine, but they have pain. And you do a CT scan and the sinus is full of mucky pus, etc. Referral to ENT surgeon to wash out the sinus to assess surgery, and that will resolve it. The question always is the sinus causing the toothache, or is the dead tooth causing sinus problems? My experience, most of the time, is the sinus causing the toothache. However, don't forget that you're a dentist and you're going to check the teeth. Sometimes an infected tooth with a cyst will burst into the sinus and cause pus there. So don't get this and go to the ENT surgeon. It's a bit embarrassing when the ENT surgeon sends back to you and goes, I think look at that tooth. Okay? So look at that. On non-odontogenic, salivary gland issues, patients presenting with neck swelling, and we do an OPG, there's a big stone in the submandibular gland, or a stone in the floor of the mouth. Again, an acute surgical intervention required, take the gland out or take the stone out, and the pain will resolve. So the salivary. Then it brings us to bony pathology, swelling. Feeling that it doesn't feel pussy, so the teeth are not coming out, CO2 positive. So it's a bony pathology not related to teeth. So non-odontogenic, you can see the cone beam scan of the ground glass appearance of the CT scan, and the CT scan shows that, which is fibrous dysplasia of the maxilla. So that can cause pain as well, especially if it starts compressing the infraorbital nerves and you get pain in the V2 distribution. You could confuse it with trigeminal neuralgia, but just shows how investigations are important. Now, this is fairly obvious. Trauma. So someone's been in a fight Saturday night, fractured mandible, broken in 2 places, stomach pain, pretty straightforward. Again, someone's bashed up, cheekbone fracture. These are all fixed surgically. Okay. Non-odontogenic facial trauma. Then it brings us to this neuropathic pain that we talked about. And it's quite often we'll see OPGs like this. They've gone to a dentist, toothache, one tooth out, gone back a week later. I think it's the wrong tooth out. The tooth pain is in front of it. They take the second tooth out. At that time they realize this dentist is useless. I'm going to go to the next dentist. They take the third tooth out, the fourth tooth out, and sometimes you get the whole quadrant missing before some penny drops in. Oh, this may not be odontogenic. It may be trigeminal neuralgia. In that case, it's medical management to start off with. I want to say, get an MRI scan. In my practice, I'll get an MRI scan for anyone I diagnose with trigeminal neuralgia, because there could occasionally be a central lesion, like a tumour in the brain, and if you just give them medications, you're going to miss the tumour. If there's a tumour in the brain, there is surgical intervention available. So don't, diagnosis is one thing, but make sure you go a little bit further and probe why. All right. I know in your description you said TMJ surgery. But this is my practice of TMJ surgery. I get referrals. So if I get 100 referrals to me, 80 patients of it will be myofascial. I do not touch them. There's no surgery required for myofascial pain patients. And thank God this is why we're oral medicine specialists. They can look after them. They're smart people, they can talk to the patients. Nicole said there's a 1 hour consultation. I cannot do 1 hour consultation, I can afford. So they go away. Then 12 patients will have internal derangement. You all know internal derangement, the disc is slipped off and they get blocking and can't open, becomes pain. They may require surgical intervention. For all of them, they may require surgical intervention. My standard line to these patients is the natural history is 90% of the patients will settle with time. And then they go, how long? And with time. It could be 6 months, 2 years, and that buys me time to work together with an oral medicine specialist. Get them involved, get the physio going, get the splints going, exercise going. And if they then come back to me and say, I can't do anything more, can you look after this patient? That's when I offer them surgery. Osteoarthrosis, it's kind of a weird made-up word I've got there. It's a problem with the bone. If there's some pathology with the bone of the joints, then surgical intervention is required. And then very fine print disorders, I'm making it small so you can understand, is tumours of the joint, and then it's surgery. So you see 100 patients come to me, 8, maybe 2 or 3 of these. Maybe 10 patients end up on an operating table at some point in time. Not straight away. So, surgical TMJ issues, not the myofascial patients. They do not get surgery. Internal derangement, as we discussed, try the non-surgical things first. So I always, the best thing to do is work with a oral medicine specialist, like a multidisciplinary team, and when they have done all the non-surgical conservative management, that's when I will touch them. The other thing is they can have pain. That's not an indication for operations. They need to have pain, functional problems. They can't open their jaw, and they can't chew normal food. So that's 2 points. And the third thing is they need to have positive radiological evidence, an MRI scan. So when all 3 of them meet, pain, functional problems, and radiology, that's when they qualify for surgery. If they have only 2 of the 3, send them away. No. And I'm pretty sure everyone agrees that these are straightforward surgical cases. We'll start here. This patient from Decay Hospital got operated on. That wasn't me, but before seeing me, that patient had 12 TM joint operations. So it's iatrogenic damage to the joint, which is when I needed to do a joint replacement. So someone should have realized by 12 operations that I'm not fixing this. So this was a myofascial chronic pain thing that became surgical, but 12 operations, then it became iatrogenic damage that required joint replacement. My conversation with him was, I can improve your joint function, but your pain is not going to go away. Ankylosis, you can see the jaw joint has become encapsulated in a ball and socket, can't move, and overgrowth of the jaw joint. Yeah? Internal derangement, this is when I was talking about when the disc is an issue, they go and have conservative management. Usually takes 3 to 6 months before an oral medicine specialist gets a feel of saying, this is not going anywhere with the splints, you need surgical intervention. So what do I do? What's the surgery I can offer? There's only about 3 things we can do, right? I can put a needle in it or a little camera, wash the joint out, give some steroids, It is a diagnostic test. I see if they respond to it. My conversation goes, about 60% will respond, which might look and improve, pain disappears, see you later, I can repeat it again. But if they do not respond to this procedure, then I start thinking, okay, there's something else required, which is this. The discus slip is torn, they can't open, then I go in there from the side, take the disc out, pour some back from the tummy, and line it and create a new disc. 80% will respond well. Not 100%, 80%. That's part of my consent process. And the third thing we can offer is a total joint replacement, which is like this. So again, multiple operated joints on here. You can see all sorts of plates and screws and everything's gone in. Multiple operation. This patient actually had rib taken and put in there to reconstruct the joint. Chronic pain, cannot open. Joint replacement. There's nothing else you can do. There's no any other biological reconstruction possible or a joint replacement. Now, only got a couple more slides. Be aware of the natural history of the TM joint surgery or symptoms of patients. If a 12-year-old boy comes and gives you TM joint symptoms, pain, don't call it myofascial pain, go to that spin down. This is what happened with this boy. He had a tumor growing there in his jaw joint. His body was changing, it became more class 3 pain in the jaw joint. In Melbourne, it took at least 6 months to diagnose as a tumor growing there. So what I'm trying to say, a 12-year-old boy does not get TM joint disorder. So it doesn't fit in the picture, investigate it further. So in brief, what it says here is surgery is very obvious when it's required. But if it's not obvious, then always delay the surgical procedure. Get the help of others. Thank you.
Hi everyone, I'm Christina. I'm one of the psychologists at PEDMAC down the road. Thanks to Nicole and Sophie for inviting me here to speak today. I'm going to speak a little bit just broadly about the role of psychology in chronic pain management, as that's a little bit of my role at PEDMAC, and give you a bit of a background about what I do there, and how it may be very similar to what a patient would experience if they were referred for a psychological input in this setting. So what I would like to cover is really just give you, like I said, a rundown about what I do, a bit of education about what a psychologist does. You guys might all know that, but some people don't, and I often find a lot of patients who come to see me don't know what that is. So it's useful to, I guess, state the obvious in some respects. The role of psychology in pain management, sort of a bit about what an assessment would look like from our perspective, and then a little bit about what we do in terms of treatment. So as I said, I'm a clinical psychologist, and our team at PEDMAC works with patients 26 years and above. So there's an adolescent team that cover younger patients. So I'll be seeing people of that age group that are both inpatients and outpatients, and there is a proportion of my work as well that is with working as a liaison with the acute and persistent pain team. So I do see a lot of the pain patients at PEDMAC as well, most of which obviously have cancer. I don't think that's probably necessarily relevant though to an overview of what psychologists do with pain, but we'll also see people that have cancer-related and non-cancer related pre-existing pain as well. So in terms of what a clinical psychologist is, basically we're a specialist field of psychology that focuses on mental health and wellbeing. And really simply, we assess, diagnose and treat mental health presentations. There are a range of things that we will deal with at PEDMAC and more broadly, everything from anxiety, depression, adjustment, sleep, things like that. And then also pain as well as a specific thing that we would target in our interventions. And generally speaking, most psychologists that are working in Victoria would have at least 6 years training and predominantly have a master's or a doctorate sort of program, just to give you an idea. most of the other speakers today have covered a little bit about pain and chronic pain and the definitions, and, you know, spoken about the fact that pain serves at alerting people to the fact that there might be an issue, but that when pain becomes more chronic, it's a little bit more complex. And so it moves from being purely a physical sensation to having sort of biological, social, emotional components. And I'll talk a little bit more about that. We also know that chronic pain is comorbid with a lot of emotional experiences of anger, hopelessness, sadness, and anxiety. And I think other speakers today have touched on that. So we'll talk about how, I guess, in order to therefore address chronic pain effectively, you really have to look at these other components as well as the medical aspects and interventions. So why is psychology important? Well, we know that psychological distress is a risk factor for developing chronic pain, but also the other way around. Those who are experiencing chronic pain are more vulnerable to experiencing psychological distress. So that's useful to, I guess, conceptualise when you're looking at patients, because one way or another, they're probably vulnerable to both. And we know that psychological factors influence a patient's experience of their pain and also how they respond to treatment. So, for example, depending on how a patient responds to their pain experience, their responses can lead to more maladaptive responses and worsen their function and outcomes. So, for example, a patient that is catastrophizing, which is really a term for worst case scenario thinking, for example, saying, I can't live with this, this is the worst thing that's ever happened to me, I hate this, how do I keep going? That's going to magnify their distress. It's going to impact their engagement with broader services that they're seeing, can lead to feelings of hopelessness, depression, and therefore that's going to have a negative impact on the patient and their outcomes. Also, if a patient has significant pain, can lead to avoidance. They don't use their body in the way that they used to, and if they stop doing that, it can lead to deconditioning, which can worsen pain. Also in the other direction, and I see this a lot with patients that I see, is that they continue to persevere doing the things that they've always done to the same level, and in overdoing it can worsen their pain picture as well. And really, I guess there's a lot of evidence just around the fact that people presenting with chronic pain experience higher levels of anxiety, depression, anxiety. And obviously this is not good for the patient, but it's also not good, I guess, in terms of healthcare costs and patients' response to treatment more generally. So when a patient gets to us, I thought it'd be useful to just touch on, well, what it is that we do. We will sit down with the patients for an hour, so we try not to get bored. That's really trying to make meaning of the patient's pain experience. And that can be easier said than done. So really, I guess similar to what you guys would do is we really ask them about the history of their pain presentation. And in doing so, we really want to assess their pre-morbid functioning, both in terms of have they experienced pain before, or is this the first time they've experienced that? How did they manage it? With patients that we might see that are going to be having other significant procedures, what's happened in the past? Have you experienced this before? Are there any life adversities that they've experienced? And how do they manage it? Get a sense of the patient's level of resilience and ability to cope with various challenges in their life. We also want to take a history of a patient's past mental health history. Have they or are they currently experiencing depression or anxiety? That's again going to impact their response to treatment, and know a bit about their background. What was their family like? What was their childhood like? What are their social supports and connections? Are they using any substances? How are they using the medications that are prescribed to them? All of those sort of things. So really, you know, this may not just be over 1 hour. Again, it can take several sessions depending on the patient. And I guess in terms of pain specifically, it's really important to understand, is the pain experience as a threat? Everyone's touched on today the fact that it's important to know whether or not the patient is just here because they want an answer, they want the medication, they want the treatment to fix it, or are they amenable perhaps to it being a little bit more complex than that. And in doing so, we want to unpick the patient's beliefs about pain. And so I guess as a psychologist, we're really interested in some of this stuff, you know, and you'll probably hear these things come out of your patients' mouths at different times, you know, thoughts about, you know, how can I cope? You know, is the pain the sign that the cancer's back, or is it a sign that something's not quite wrong with my tooth, or whatever it is that they might have presented for in the past, all the way through to the sense of hopelessness, nothing can help me, you know, will this ever be improved? And for us, I guess we want to know this stuff because this is what we target with patients. And in doing so, I guess, what we want to do is understand, we want to work with patients first and foremost to help educate them on what's going on for them if they're experiencing chronic pain, and letting them know that there are a range of factors that contribute to their presentation, including the sensitization of the nervous system, and also, I guess, the negative impact that having mood or anxiety issues that aren't managed properly can also exacerbate their pain response. And what we'll then ultimately work with people is on thinking about pain differently. So some of those thoughts that I just showed you, working with people to go, can we adjust them? Can we tone those down so that they're less severe, that they cause less distress, that they're less magnified? We also work with people on doing the things that are important to them, doing more of that, because often when people are experiencing pain, that goes out the window. They don't do the things that they used to do. They don't go out of the house. They don't go to that birthday party. They don't go out for coffee with their friends. And that can have, again, a negative response on how they're going and pacing their activity. And there are two types of treatments or therapies that we probably use a lot. And I'll just touch briefly on those really quickly. And they're cognitive behavioural therapy and acceptance and commitment therapy, which are very, very similar. And they both have a good evidence base in treating chronic pain and have been shown to be effective on a range of different sort of outcomes, which I've mentioned there. So I guess it's sort of apparent in some of the things that I'm saying, but cognitive behavioural therapy is really about encouraging a person to change any unhelpful thinking, patterns or behaviours that might be contributing to what's going on. So we work with people's thoughts, behaviours and emotions to try and develop more adaptive ways of managing their pain, so that it makes things a little bit easier for them, but then ultimately as well can have a positive impact on their pain presentation. And we'll do this via a range of different tasks and targeting different things, and that will probably depend on the patient that we're working with, what's going to work for them, and ultimately what their issues are. But this can include educating people about the pain experience that they're having, working on goals and goal setting, as I touched on before, looking very specifically at their pain-related thoughts and cognitions, learning relaxation techniques to kind of tone down and cool down the nervous system, looking at their behaviours in response to pain, including pacing, and also how are they sleeping well, all these sort of basics. Are you getting a good night's sleep? Are you eating well? Things like that. In terms of, I guess, one of the themes that sort of come up today is patients continually going from one clinician to the next. And so I guess when we're all seeing patients, it's important to think of we're one of those people in that chain. We don't know necessarily where the patient is in that chain. And so I guess it's an opportunity for us to be thoughtful and educate patients about what the process is so that we're not necessarily unnecessarily reinforcing that solution or cure focus if that's not necessarily what's going to be the outcome for the patient. So I just talk to people about really thinking about giving people adequate information and expectations about what's going to happen. And then, like everyone else has said, really having time to ask and answer questions that patients raise with us. And you can also support, I guess, positive self-talk for patients and help us with some of the work that we're doing with patients by just reinforcing how patients are coping, how they've coped before and how they'll continue to cope. And then refer on appropriately, and doing that through either your specialist colleagues, the patient's GP, or other specialist pain management services, of which there are a number of public services that deal with chronic pain here in Melbourne. And that's me. And there's some references there as well if people would like to have a look.
Actually, Christine, a couple of questions come through. Is there anything that we can do as professionals to assist patients' management assist patients' management of pain from a psychological perspective? If you want to just touch on.
I guess that probably comes back to one of those last slides that I touched on, which is really hearing the patient's story, listening to what's going on, and being really mindful and thoughtful about what you offer to the patient and what you feed back to them in educating them about the process and what to expect if they're moving on to another professional as well. Often I think patients can get caught in this loop of expecting that there will be a solution, that there will be a focus, and I guess the earlier the patients can be sort of educated and have appropriate level expectations, I guess will impact their level of investment in there being a complete solution. And really as well, just reinforcing positive coping strategies that the patients have had. You know, if you're unable to do the other stuff because it's not your remit or you don't understand it enough, is really sort of going, you know, you're doing okay, you're managing really well. Is there anything else that you need? Who can you talk to about that to encourage them to activate their current resources that they're using appropriately? And if they don't have resources in certain areas, pointing them in the right direction of where they might be able to get that.
Thank you. Yes, to you, Nicole. What's your recommendation for managing pain in patients who are on long-term pain modifying medications for chronic pain?
So patients, I'm not going to say who asked that question, but so patients that have come to you that are already taking that are already on numerous pain medications. Okay. Once again, it's reassurance, education, counselling. We do prescribe, but we don't do it willy-nilly, and we always prescribe thinking, you know, is this patient going to get an exit strategy? However, when a patient comes to you and they've already got this long list of medications that they're on, that should actually be a warning sign to you. And I always ask them who prescribes for them. Do they see specialists? Sometimes they might have more than one GP, and GPs don't necessarily know each other. And so basically, I make it very clear from the outset that the patient is not getting a script from me for painkillers. Okay, and then you have to basically explain that, find out why they're on what medication, each medication that they're on, find out why they're on it, what their understanding is of why they're taking it, because you just can't keep adding to that. So it's really about alerting yourself and the patient to the fact that, well, clearly all of these medications are not curing you, you've still got pain. So why are you taking this? So basically it's just part of the overall management. We don't like to start patients on medications if we think that they're going to have to then be coming back to us for the rest of their lives to just be getting the same scripts, and we involve the GP. So it's also a good time to then make contact with that patient's doctor and find out where and why are they getting this medication, and sometimes start to dial it back. Would that help?
I think that came through. Next through for Ricky. Ricky. So where was the site for the tumour, the 12-year-old?
The left condyle.
Okay.
And it invaded the infratemporal fossa and just flooded the face as well.
Okay, and one other question in relation to the 12-year-old boy. What type of imaging is required and who to refer to?
It was interesting because he had an OPG was essentially normal. So an ECG wouldn't have shown that, so it required an MRI scan. And for an MRI, you probably have to refer to a specialist, max to organise. But sorry, can I just say, the point is not that you need to recognise that he needs an MRI scan. The point was to recognise that a 12-year-old boy shouldn't get joint issues, so you need to refer, say, this is not right.
Another question that's come in. Was the photo of the man with the huge swollen neck an example of Ludwig's?
Correct.
angina?
That was post-surgery from drainage by Ludwig's angina. So 3 drains, bilateral submandibular and submental region.
That's it that's come through, unless there's any other questions.
So I'd just like to thank everyone for coming today, everyone that presented, Stephanie, Brad, Ricky, Christina, and also thank you to Nikki for organising it today. And see you at the next friend round.